don't have specific projects for them necessarily, but they need to be kind of embedded throughout all of our work plans and projects. The other two domains that are part of Initiative 1 are care delivery redesign, which is domain 2, and prevention and health promotion, which is domain 3. In each of those domains, the healthcare authority gave us an option basically of 4 projects in each one. We had to choose one in each domain, and then we had an optional one. Our ACH chose all 4 projects in domain 2, which is bidirectional integration of physical and behavioral health, community-based care coordination, which is Pathways Hub, which is what we're here for, transitional care and diversion interventions. Those are 2 projects. And then in domain 3, our ACH chose, we're obviously doing the addressing the opioid public health crisis. That was a required project for all ACHs to address. And then our optional project for domain 3 is chronic disease prevention and control. So this slide just kind of walks through what each of the goals is of each of these projects. So the first one is bidirectional integration of physical health and behavioral health. And this is happening in our ACH through what is called the Whole Person Care Collaborative. I think that most people that are here and on the phone are pretty familiar with this, so I'm not going to go into it very far. But if you want more information, there is a little packet at the end of your document that has a little bit more information, and you are welcome to contact any of our staff for that. Community-based care coordination is this project is the Pathways Community Hub, and it promotes care coordination across the continuum of health. And we'll obviously be talking a lot more about that one today. Transitional care is transitioning people out of high-cost acute care settings to hopefully so they do not come back into them, so making a smooth transition out. And diversion interventions is preventing people from coming into high-cost acute care settings in the first place. Those acute care settings can be either emergency rooms or emergency departments, hospitals, jail settings, long-term care facilities, those types of things. The opioid use public health crisis is focusing on 4 main areas, which is preventing opioid use, treating opioid use disorder, opioid overdose prevention, and long-term recovery and supports. And then the last one is chronic disease prevention and control. And this project is also being addressed through the Whole Person Care Collaborative, mainly through primary care and behavioral health providers. And with these, we have 6 projects and we have 4 work groups with our ACH. So we have the Whole Person Care Collaborative, which is addressing the first and last projects we talked about. We have this work group for the Pathways Community Hub. We have an opioid work group, and then we have one work group that is doing both transitional care and diversion interventions. They've all started meeting. This is the last one for us to get going. And they're all kind of at different places, but they're working on developing their plans, picking their evidence-based approaches, and selecting target populations. And we are working hard to try and make sure that all of our projects overlap or reinforce each other. They're not siloed projects, so that where there are connections, we're trying to make them and really support each of the projects together. Like I said, there's a little bit more information at the back that talks about each of these projects. The Medicaid Transformation Toolkit, Project Toolkit, is where a lot of this information comes from, but it's kind of a long, dry document. And you are always welcome to contact staff to get more information. Resources and relationships, like I said, we're trying to make sure that these projects are not implemented in isolation, that each of them are being connected. So if there's different partners in implementing different projects, we want to make sure that they're getting connected. The transformation projects must be based on community-specific needs for the Medicaid population. So the Healthcare Authority did give us this toolkit of projects to pick from, but we as an ACH and community partners coming together are able to tailor them to what our community needs. So it's not necessarily, the same across the state. Obviously, we have very specific needs and different challenges and barriers. One of them is being so rural, and so we're able to adapt our plan to meet those needs. And regional projects will be assessed based on achievement of defined milestones and metrics. What that means is that they say over and over, this is not a grant. We have to earn our money. There are certain milestones that we have to meet, certain performance metrics that we have to move the metric and improve on in order to draw down the money. As Linda said, we did do the project or the certification process and the project application last year, and so we have gotten our first round of funding, basically, but we'll have to continue to meet these milestones and metrics in order to continue to get funding. So that is the really quick version of what the Medicaid transformation is. Does anybody have any questions about it? Okay. So next up on our agenda is to introduce the technical assistance team. I will let Kathy Burgoyne do this, but first I wanted to say that the North Central ACH has contracted with these three organizations to provide technical assistance. They have implemented and planned MAID hubs in other places, and so they're really the people that know all about this. So Kathy, do you want to introduce yourself and the others?
Thank you, Crystal. I do. So there are three organizations that have joined together to provide technical assistance training and whatever support you need to be able to have a fully functioning certified Pathways Care Coordination Program and Hub. And those three organizations, I'll tell you who they are and who the leads are. From the Foundation for Healthy Generations, that's who I work for, and the lead on that is me, Kathy Burgoyne. Our role is overall coordination and helping to tailor any of the work that specifically is related to Washington that may be different within the context of the waiver, and then to also try and do cross-ACH learning so that people have support for whatever they're doing. And at the very end, we actually have created a sustainable system to support the Pathways Hub. In addition, the Foundation for Healthy Generations has hired 2 people to be certified as Pathways Master Trainers, so that we'll be able to respond to the training needs across the ACHs in the most flexible, nimble, and responsive way possible. The Pathways Community Hub Institute, the lead for that is Sarah Redding. Sarah and her husband Mark were the founders of the model. Sarah has run a hub, and she has deep experience and knowledge about how this works in real life. And between the two of us, we'll be working together to try and think with you about how Pathways intersects with all the other toolkit projects that you're moving forward. And then the third organization is Coordinated Care Services, and they are responsible for the business and work plan development of Pathways. So, and then finally the data system. So they're sort of that nut and bolts people. And Adam Borat is the lead for that for our ACHs in Washington. We set up weekly calls with Crystal so that we were able to be nimble and responsive to your needs, as well as in the near future, we'll be setting up cross-ACH calls. I think that's it. I'm happy to answer questions.
Anybody have any questions?
That's your team.
Cool.
Great. Thanks, Crystal.
Yes.
This is Winnie Adams from Coordinated Care. I just had a question. Is this same team, the team that's working with the other ACHs, or how is that split up? Are you kind of splitting and conquering, or how is that set up with trying to meet the needs of the rest of the ACHs in Washington State?
All three of our organizations are supporting all 6 of the ACHs that are moving forward with Pathways.
Thank you.
And so there's some, we've tried to the degree possible to set sort of, here's our leadership and expertise, but we also have secondary and backup people within each of our organizations and are doing a lot of cross-learning so that we can be as supportive as possible.
Cool. Any other questions? Anybody on the phone have a question? Okay, so the next thing on the agenda is for Dr. Sarah Redding, who was just introduced as part of the technical assistance team, to give an overview of the Pathways Community Hub model. So Sarah, you can go ahead and start, and when you're ready for me to go to the next slide, just say next slide.
Thanks, Crystal. Hi, everyone. This is Sarah Redding, and I'm just going to give a brief overview because I know some of you have been through this before, so this will be review for some, but for those that haven't been exposed to the model much at all, at least to give you some background information. So Crystal, go ahead to the next slide. I put this slide up here just to show that the model's been around for a while. We actually are a bright spot under the Institute for Healthcare Improvement. We just received an endorsement from the Robert Wood Johnson Foundation. We've worked with several of the federal agencies, especially the Agency for Healthcare Research and Quality, who put several publications out about the model. So this is just kind of to reassure you that we're not the new kid on the block. We've at least been around long enough to be recognized by some of these organizations. So the next slide. I always like to go back to why do we need another model, and why I think we need another model is described in this white paper by the Agency for Healthcare Research and Quality, and they were really looking at how does the medical neighborhood actually coordinate with the community, and what they found in their national survey is highlighted in yellow, that the connections between primary care and community services are simply absent or highly fragmented and disorganized. So while we can have a very good functioning healthcare system, when they go to reach out to the community side, things can fall apart at that point. Next slide. I also like to point out with this model that this is really about community-based care coordination. When you say care coordination, it means different things to different people depending on what lens you're looking out of. And certainly if you're coming out of the health system, you're thinking often around healthcare coordination. We're really that dark blue oval on the right. You know, we're not intending to disrupt what's going on in the health system or in direct services. We want to partner and bring in information into those systems, but we're really focused on what's going out in the community. And so when I talk about a community care coordinator, I'm talking about somebody who is spending most of their time out in the community, doing home visits, seeing people where they live. I will slip a lot and say community health worker because the model was designed using community health workers, but we fully recognize there's a lot of other people out in communities doing that type of work. And there's no limitation to who could be a community care coordinator, but I'm just saying up front I may slip and say community health worker a lot. So the next slide is kind of the basics of the model. It's pretty simple. Find the right people at risk. This is not a model for everybody. This is a model to go out and find those folks that are living in your region who are having the worst outcomes and driving up costs for everybody. Once we find them, we want to do a comprehensive risk assessment looking at all of the risks, not just health risks. We really want to look at, do they have social support? Do they have legal needs? Are there substance abuse issues? So a very complete assessment of what's going on with that person. In our model, once a risk is identified, it is translated into a pathway, and we'll talk a little bit more about that in a minute. And then we measure everything that we do. It's a very data intensive model because that's how we find what's working and what's not working. So the next slide, just to start off with, why are we doing this in the first place? It's to really help people and families. So I often start with this typical family at risk, and I'll randomly pick, I'll pick Marcus today. Marcus is a 6-year-old. He's been to the emergency department twice in the past month for asthma exacerbations. And the emergency department provider has seen him both times he's come in and realizes that everything that was recommended on the first visit didn't happen by the second visit, which was, gosh, you need to see your medical provider, you need to have an asthma action plan, you need to get your medications, and make sure you're taking them correctly, and we need to get you back into school because you're missing too much school. And so often what happens is there might be a program that has an asthma educator that's sent out to meet with Marcus and his mom. And when that person enters the family and enters the home, finds that not only is Marcus having trouble, but mom's actually pregnant. She's newly pregnant. She's been really sick this pregnancy. She's a single mom, just lost her job because she's missed so much work. And the reality is the only place this family can move is with grandma across town, who just found out she has type 2 diabetes. She's a smoker, and now she's so stressed out she's increased her smoking to 1.5 packs a day. So this is a really typical situation that somebody walks into thinking they're going to deal with one issue and find that there's many people in this family unit that are at risk. And if we go to the next slide, in most communities, unless you're very, very rural, and I've worked with one hub that's situated in frontier communities, frontier counties, there are a lot of resources. The problem is, just like that white paper said, the resources are fragmented and disorganized. So a family like this could have 3, maybe 5 care coordinator type people coming into their home offering very siloed services. Marcus might have the asthma educator. Mom might have a case manager from her health plan. Grandma might have been referred for diabetes self-management classes, but these care coordinators aren't talking to each other, and very often families can get frustrated with that. I think the most I've heard of so far was when I was working in Minnesota, and one family had 15 care coordinators in their home within the past month, and they actually stopped services with everybody because the system had so overwhelmed them. So if we go to the next slide, I'm going to show you what this might look like with a hub in place and then talk more specifically about the hub. So this is one of those transition slides, Crystal, so you might just go ahead and push a bunch right now. So if a care coordinator was sent out, a hub-based community care coordinator was sent out and to meet with Marcus and his family, the very first thing that she would do would be to check in with the hub and to make sure that they weren't receiving services somewhere else. Because as we piloted the model, the first thing we found is there's a whole lot of duplication out there, which is we have way too many people that need services. We don't need to be wasting our time seeing the same person. So if that family is not engaged with the hub, then all of the agencies that have agreed to become part of the hub network have also agreed to use the same data collection tools. So they will use the same demographic intake, the same checklist. The initial checklist in our hub world is that comprehensive risk assessment. They'll use the same pathways to track risks. They will go out on a regular home visiting schedule, and they will discharge this family when the risks have been addressed. So the hub itself is functioning really as air traffic control. The hub isn't coming in trying to replace anything that already exists in the community. It's coming in to say, what do we have and how do we support it and make it work better? And how do we give the tools and increase the funding to support these community care coordinators that are so important in actually getting people better too? So that's really how the model looks. If we go to the next slide, there are 20 core pathways. I mentioned the pathways earlier, and these pathways, which are listed here, are standardized. So when you implement in your region, you're using the same measurement strategies we're using in Ohio and in Maryland and other states that are using the model. The next slide shows why it's so important to standardize. Because all of these pathways are consistent, we were able to work with a national group of payers to help develop standard billing codes. So everything that we do within the model has a billing code and a modifier that we can actually use to track those services and then invoice to whoever is paying for those pathways. Next slide. In this model then, that typical family at risk, when that care coordinator is going into the home and identifying it's not just Marcus, it's mom and grandma that need help too. Each one of those folks would have a comprehensive risk assessment done. They would have pathways assigned to them as an individual, and those pathways will be monitored through to completion. Recognizing that we're not in a perfect world and we can't get to the completion on all pathways, we can at least track everything that we did to try to get to completion and what the barriers were, what stopped us from finding mom safe and stable housing, and what stopped us from actually getting Marcus a new medical home. So the model's pretty strong that way, with the data being able to give us a bigger picture, not just at the individual level, but also at the community or regional level about what's working and what's not. Next slide. Again, because we're using the same measurement tool, the same pathways, we can start to compare how are individual care coordinators doing, how are agencies doing compared to one another, how are different communities doing, and not in a punitive way at all, but often we'll find that there is somebody who's really figured out how to do something well, and we try to use their best practice to teach everybody else. So in Ohio, where we have 6, soon to be 7 hubs, we meet on a quarterly basis and we share our data and we share information and try to learn from each other how to do things better. And that's really a huge benefit. Next slide. In our system then, what we're trying to create with the hub in place is to bring all these fragmented, disorganized care coordinators that are all trying to do the right thing together through the hub structure. And we can also bring funding through the hub structure so that we're really trying to create the resources to have one primary care coordinator for a family unit. We don't want 15 people in a family. We want one that's trusted and has built a good relationship and can actually be there through the long journey with having, it takes months, sometimes years to resolve some of these issues. So we want to be able to keep that care coordinator with the family as they're working through those tough issues that they need to address. So the next slide just shows the model has grown to become a nationally certified model. Certification lives at the Rockville Institute in Maryland. Any hub must go through a process to become certified. They have to meet prerequisites and standards, and that's a big part of my job in working with the ACHs, is to build your hub from the very beginning to be able to meet those standards. That's been really important for us in contracting, because obviously, funders want to know that you're following a certain level of quality in the work that you do. So if you're curious, you can go to this website and download those prerequisites and standards, download the 20 pathways, and see some of the other hubs that have been certified across the country. So the next slide is just a simple diagram of what are the key parts of the hub. And so there's the hub itself, which is pretty small. The hub, again, isn't doing the work. So it's a small neutral entity that is playing that air traffic control role. But then we have to have those contracted care coordination agencies, or what you see as CCAs here, that actually employ the care coordinators. So every region, every ACH is going to have their own variation of what that network looks like. Then we have to have referral partners. Who's going to be out finding these people that are most at risk and making referrals into the hub? And who will be the payers? And hopefully, and what we see as hubs mature is there should be a variety of payers. You never want to have just one payer, and actually you have to have 2 payers to be certified. But you want to have a variety. It's not just healthcare that's going to benefit from having this system in place. it's the legal system, and it's the schools, and there's multiple other folks out there that are going to see an improvement in outcomes, not just health outcomes. So the final slide is actually a worksheet that we use with new communities to try to start to actually fill in the blanks. Okay, who, and you're going through this now, who will be the hub entity, and how are we going to find that hub entity? How are we going to pick our target population? Once we pick that population, who are the appropriate care coordination agencies to partner with first, and what's our kind of staging plan to grow the hub? Who are those other partners that are going to be providing direct services or sending referrals into the hub? And who are the potential funders that are going to keep this hub sustainable over the long haul? So that's my last slide, and that's just, I know, a very brief overview, but I would be happy to take any questions that you have.
So this is Caroline from the North Central ACH. I was going to wait to see if anybody else had questions, but I have a couple questions, Dr. Writing, related to the target population. So if as a region we choose a target population, how do you reconcile that with the fact that some household members in your model that you just showed may not fit the criteria for that target population? So how do you balance that out? If the model is to kind of address the whole family, do you just, the target population is what gets you in the house and then you address the whole family? Or how, can you talk a little bit about how you reconcile that?
And that's the vision of a mature hub, you know, so one that has built up. No hub starts out being able to serve everybody because it's too much to bite off at one time. So in Ohio, all of the hubs that established there started with maternal and child health population because that's where the interest was at the time for funders and payers. And it's been over time that the at-risk population has grown to taking on adults with chronic conditions and opioid, people dealing with opioids and other high-risk populations. But you have to start somewhere, and you have to start relatively small because there's a lot of learning going on with this model. So you may start out where you do limit it, and it really is, hey, we're just going to work with this target population until we've got our feet wet and we know what we're doing and we feel like we can handle that, and then we're going to add on the next kind of concentric ring of people at risk. But I would not advise you to start out to be able to cover everybody at the beginning.
Mm-hmm.
So this is Lael Duncan. I'm from Okanogan County, and as I look at this, one of the big questions in my mind has to do with geographic coverage, because we have such a huge area to cover, and I'm just wondering how that can work in terms of the coordination.
Right, and that's where, I mean, you're in a unique situation where you may only have one care coordination agency able to serve a certain geographic area. And so as your hub develops its referral strategy, you know, if a referral comes in from an outside source and that person lives in that area, it's automatically going to go to that care coordination agency. And that's where it's not a cookie cutter approach. It's really sitting down and saying, okay, who do you have out there? Maybe we need to help support building a little bit more in that community because there really isn't enough capacity on the ground to be able to do this work. Those are all the things that your hub is going to have to look at as it starts to build.
Okay, thank you.
Sure.
Any other questions?
Can I just get clarification on Caroline's question? So I understand not targeting all populations, but if you have somebody within a family that is within the target population, have you seen that the care coordinators tend to care for that whole family as a whole on that unique basis, or is it letting them know that they won't receive care coordination until our capacity has increased or understanding has increased of the process?
You know, I'll tell you, in working with care coordinators, whether you tell them to or not, they're going to work with those people in the family. It's just whether they tell you that they are or not, because that's just who they are, which is great. It's really going to have to be, some of the ACHs are really intent on getting numbers and showing outcomes quickly. And so if that's the case, then you have to be a little bit more strict in the beginning with who you enroll as a client or a participant in your hub. It's going to be up to you to decide that. I mean, so if you want to have a little bit of flexibility with that and say, as long as you have the key person from that target population enrolled, we would like to take care of those family members. The problem is these families can get pretty large pretty quick. So it's a balance of what's your capacity, how quickly do you need to get to the numbers you need to get to show your impact. All of those decisions have to be weighed in, but we're not telling you that. That's your decision to make as a hub.
And piggybacking on the multi-county geography question, have you had experience in other communities that have rolled out a hub across multiple counties and how they've gone about starting it and then scaling it? Like, have you typically seen it start in one county and then scale to the other counties? Do you have any thoughts there for us?
Yeah, that is the typical way I've seen them grow. And I've seen hubs, that cover 6 or more counties. But they usually start in one area. Now, I have seen in more rural areas where it's a 3-county hub from the beginning, where they just say, we have to be this big because there's not enough of us in one county to do it this way. So it's possible, it is possible to do a larger start if you're more rural. I mean, you have a fair number of people, though, if you've got 94,000 lives. What were you thinking of your start? Have you had discussions around that?
We haven't really had discussions around it yet.
And if we have the time for the full data presentation today, we can start kind of thinking about that by looking at the data.
Mm-hmm.
I have one more question, but I don't want to take it all up, so I'm just going to be quiet. See if anybody else has any.
Your question might be valuable for all of us, so can you ask it?
So one thing that I still struggle to understand, Dr. Redding, is if there's one hub care coordinator that is trying to avoid duplication, what happens to those other 5 care coordinators that used to be there?
Well, often you've got 5 people coming in, all trying to work on a variety of different versions of the same thing. I mean, everyone might be working or dealing with transportation issues, even if they're coming in to talk about asthma. So it's that concept of that one identified, kind of like a primary care physician, but a primary care coordinator. You bring in other people as they're needed. So if you need somebody to come in and do, specific diabetes education, you still offer that service. It's just when that person comes in, they're not going to be dealing with housing and transportation and all of the other issues that a care coordinator might deal with. So it's using your resources more specifically.
So is that equivalent to having a case manager who manages all of the referrals and tracks the progress of the referrals, as well as providing hands-on management?
Yeah, I mean, I think there's some similarity with that model. It really is just that it's almost like a not a gatekeeper, not letting people in, but just making sure that the family's not overwhelmed. And that,
right.
Whoever that primary care coordinator is tasked with making sure those pathways are completed, because they won't get paid unless those pathways are completed. So they're going to bring in the resources they need to get to a successful conclusion. And that's what we see in communities. It's not that, I'm just going to keep this person and nobody else can come in. It's like, help me because I need to get them to complete this outcome so our agency gets payment.
Right. Thank you.
Great. Any other questions? Is there any more thoughts? All right. Thank you, Dr. Redding, for that overview. So now I'm going to transition to just talking a little bit about the nuts and bolts of this work group and what this work group is supposed to do now that everybody has a general idea of what the hub is. To start with, our board approved a work group charter, and I just put up here a small part of that charter, and those 4 bulleted points are really what the charge of this work group is. The next slide will have some responsibilities, but one of our main things that we need to accomplish over the next 4 months is to select an organization or recommend an organization to serve as the lead agency. So somebody to serve as that hub. We'll learn a little bit more in some of the standards and prerequisites that it needs to be a neutral agency and it needs to serve all 4 counties. And so there's kind of some requirements around that. We need to select that lead agency. We need to select the initial target populations or population that we're talking about, and how do we start, like what geography we start in, or what health need do we start with, the initial focus outcomes and related pathways. And then also we want to be thinking about our scaling efforts and including amplification opportunities and mitigation of risks. And so this is to note, like if we start in one county, we're going to need to go to all 4 counties. Or if we start with a really, a very narrow population in all 4 counties, how do we expand it? So just keeping that in mind while we're doing this. So that's really what currently this work group has been formed to do. And also in the charter are the member responsibilities. The first one is to participate in 75% of work group meetings. And I know that everybody is busy and it's difficult to make these meetings. The reason that we ask for you to participate in 75% of meetings is so that you're able to stay informed with what's happening. And so, because as we go forward and decisions have to be made, we have to have some kind of continuity of understanding where we're at in the process. The second one is to commit to being well informed on the Pathways Community Hub. There will probably be a little bit of extra reading, not a ton, but just to really understand this Pathways model and how it will fit in our community specifically, because we want to be leading this process. We don't want to just take what's happened someplace else and say, okay, we're going to do this. We want to make sure that it fits and that we're adapting it to our community. Work with the lead agency and staff to develop a detailed project implementation plan. These are due to the Healthcare Authority in September. I'll show you a little timeline next. And this doesn't mean that you guys have to write this plan, but just help us develop it, give us feedback and guidance on it. Ensure milestones are met. Those also come from the Healthcare Authority. And assure that recommendations made by the work group are in alignment with attaining National Hub certification. This is what Dr. Redding talked a little bit about. And obviously we're going to get a lot of technical assistance from her and making sure that what we're doing is going down the track of being able to become a certified hub. But we want to keep that in mind. Communicate with other members of your sector and the community to ensure broad input into this work group. So if you're representing a sector or you have partners out in the community, letting them know what you're doing, getting input on it, like understanding the populations that are most at need of, community-based care coordination is really helpful to be able to bring that back to our work group. And then the last one, use strategies supported by regional data to advance equity and reduce disparities in recommendations made to the board. So we'll be bringing data to the work group, data that you guys can provide, or anecdotal data is helpful also. Okay, so this slide shows kind of the 3 stages that the Healthcare Authority is envisioning for the Medicaid transformation. What we're in right now is 2018, and they're really talking about it as a planning year. 2019 is the implementation year, so all the projects should be launched and actually running operational. And 2020 and 2021 are scale and sustain, so those are the years when we would be expanding our populations or expanding our geography. We want to get to implementation as soon as possible, because the sooner we implement, the faster we'll make changes. And then this is kind of some of the key questions that we would be asking at each of these stages. So in stage 1, this year for 2018, the first question is what evidence-based approaches should we select? The toolkit only gave us one evidence-based approach, so that
So you're ahead of the game.
yeah, that decision's been made. The other work groups had to select from a number of evidence-based approaches, and so that was a process that had to happen earlier for them. We have to select our target population and how it will change or grow over time, where we begin and how might we scale, things that we already were talking about. How do we identify early implementation partners? So that might be like our first set of care coordination agencies. How do we find them? And what does our funding process look like? In next year, during implementation, the questions that we'll be looking at are what is our reporting process? What data do we need to monitor progress? How do we know that what we're doing is working? What changes do we need to make? What technical assistance can we recommend to partners? So that could be helping care coordination agencies that are struggling with something. You know, how can we help them get extra training that they may need? And now that we've begun, how will we expand our project's reach? So that's really going into the stage 3, scale and sustain. How do we make it a region-wide approach if it's not already? How can value-based payments sustain the good work that's happening? And what other funding might sustain this work? And so that's a part that's already built into the model that Dr. Redding was talking about, where the funding comes from once the demonstration is over. But it's something that we need to be thinking about because we need to be building a process that we can get funders to continue this beyond the demonstration to pay for the care coordination activities. This is probably pretty small if you're in the room. This is the 5-year timeline that we've pulled out of what the Healthcare Authority gave us in that project toolkit. In 2017, our big milestone was completing the project application. We did that. It kind of gave a rough outline of what we wanted to do in each of the projects, but there were still a lot of decisions that needed to be made. Coming up in 2018, our milestones, we have 2 deadlines basically. One, the end of June, which for that milestone, we have to have our lead agency identified and our target populations selected. And we need to identify as best as we can our implementation partners. So that would likely be our care coordination agencies and referral partners at that point. And then it's on September 30th, we have due to the Healthcare Authority our completed implementation plan. We don't yet know really what that looks like. They'll be releasing a template, I believe, in March to give us a better idea, but we'll have to detail how we're gonna plan this year, implement it next year, and scale it and sustain it. Are there any questions about what the work group is designed for, what our deadlines are? Anything? Nope. Okay. So, as I said, one of our big tasks is to identify a lead agency. Our current thinking is that we would go through some kind of RFP process. And I should note that all the other ACHs that have selected the Pathways Hub have decided to be the lead agency themselves. So our ACH is a little bit different in that we don't want to be the lead agency. We want a community organization to hold that role and to keep it going beyond the demonstration. And that was a decision that the board made. And so the work group is kind of carrying out that work. I'm hoping for 6 to 8 volunteers, just a small group to help us develop this RFP or the process for selecting, identifying this lead agency. It doesn't, there will be some eligibility criteria that we need to develop. It'll go in conjunction with what those standards and prerequisites are. We also want to incorporate the local context for determining who that lead agency should be. What are realistic demands? It may not be the same here as it would be in Seattle. So we have some flexibility there. And so this group would meet I'm thinking like maybe a phone call once a week or every other week for the next month or so to get to a process that we think would work for identifying a lead agency. The one constraint is that if your agency intends to respond to the RFP, probably not appropriate to be on this subgroup. So if your agency wanted to apply to be the lead agency, yeah. So is there anybody that wants to throw their hand up and volunteer to be on this?
Well, this is Lael, and typically I'm that girl with her hand up all the time, but I do have a question about the potential to be a lead agency.
Yes.
I don't know if we would be applying or not because I'm not really clear on all of the criteria that's involved. So initially I would be interested in assisting however I can.
Okay.
And I would certainly withdraw if it became apparent that it was something that we would be interested in, but I just wanted to disclose that.
Okay, that sounds good.
Okay.
Anybody else?
This is Sheila,
Yeah.
and I don't mind
Yeah.
helping.
Thank you, Sheila. Wait, making eye contact. Brooklyn?
I want to kind of understand. So with the city, we've developed RFPs, and we've had, like, if it's for a social service agency or like a program that we want one of our agencies to administer. And the process in developing what would be the most functional, what would look the best, those agencies are the most equipped to provide that type of information. And so we've always had almost all of them at the table to help identify what are things that work in this community, what are things that don't work in this community, how is coordination already taking place, what are realistic expectations within the program, because we used King County's program as an example, and that was obviously a multi-million-dollar program, and ours was not, but it was really helpful to have their insight.
Mhm.
And if they wanted to participate, they were able to. If they didn't want to participate, they were able to opt out. And then once the RFP came, we offered a either individual meetings to say, hey, let's walk through this RFP, whatever questions you have. We didn't open kind of thing. And so it's a really open process when the way that we do it. Why would we not do that for this?
So thinking so this is up for discussion for sure. But the thinking was that because we'll be developing that eligibility criteria, that it could potentially be like a conflict of interest, right? Like if you want your agency to be the lead agency, you might kind of sway what is eligible.
In terms of,
but I think it's okay.
sorry, what's the eligibility criteria?
There's, it's basically from the standards and prerequisites, but you have to serve, as I've read them, you have to serve all 4 counties, right? That's one criteria. You have to be neutral, so not provide care coordination services yourself, not be a healthcare provider, that type of ththing.
Maybe they adjust that on phone.
Dr. Redding or Kathy, do you have any other comments?
I feel like I'm willing to help, but I don't think I'll be helpful.
Gotcha.
If that makes sense. And because I don't have that expertise, I don't have that insight into how should an agency even think about providing the service. I have no idea. I'm happy to be a non-interested party because the city's not going to apply for this, but I'm also probably not going to be as insightful as a lot of the other people that are sitting at this table.
This is Sarah Crystal, and I think when you pick your work group, maybe one of the very first meetings is to go over those prerequisites and standards so you have a really good understanding of what that hub entity needs to look like.
Yeah, we can do that.
But you're right pointing out the neutrality. I mean, the hub, that's a big part of the hub. It just can't have its own care coordination staff. So in some ways that eliminates a lot of people right off the bat because they may want to participate as a contracted agency.
Yeah, this is Lael. That's out for sure, and that's fine. I'm happy to still participate.
So Dr. Redding, this is Linda. I have a question. With our ACH board and all the ACH boards, it is required to say at the beginning of a meeting if you have a conflict of interest in any part of the meeting that's going to go on. The question that Brooklyn asked, and she is one of our board members, if there's potentially people who are, or entities who are interested in applying for the RFP, if they stated at the beginning, there's a potential conflict of interest because my agency's interested, would that solve that problem? Because I agree, it would bring up a valid conversation when you have people who know more than others, if that would work.
Yeah, I mean, I certainly don't have a, I mean, and I don't want to get in the middle of the decision, but I think if you, it's really going to come down to who can qualify and meet these standards. It's not like you can come in and change what the standards are. So I think it's always good to have more minds trying to solve a problem. And maybe as you're creating this RFP to have it more realistic for the folks you know might apply for it is not a bad thing.
Thank you.
We'll take that constraint off.
Crystal, this is Virginia O'Kelly. My question to Dr. Reddington is, could she describe one or two agencies that she has seen become a hub and what was a little bit about their background? I'm trying to just visualize the agency that would be knowledgeable enough about care coordination, yet not provide care coordination themselves.
Yeah, and actually the hub has to be very good at business because they're doing a lot of contracting. So some of the hubs, I'm thinking our own hub, the original hub is a nonprofit organization. Another hub was a nonprofit developed by 4 competing hospitals that stood up on nonprofit. One hub, the one in Albuquerque, New Mexico, lives at the University of New Mexico. There is a hub in Milwaukee, Wisconsin that, again, a community-based organization that formed. It was a newly formed organization to take on that role. So there's a wide variety of organizations that can step up to be that role. But honestly, you need staff at the hub that understand care coordination, but you need staff that are very good at thinking through business problems too, and quality improvement and reporting and things like that.
Thank you.
So this is Kathy. I actually think this is really key, which is understanding the function of the hub, which is really operations and infrastructure. So contracting with the care coordination agencies, gathering the data from all the care coordination agencies, billing once you get that contract, looking at the data and figuring out where we're doing well, where we're not, pulling together meetings of the care coordination agencies and care coordinators to address either training needs or sort of what comes up, really monitoring the data to make sure that what's being implemented is a high quality program. So it's not necessarily an organization that does care coordination. We did agree on our last call with the ACH that we would sit down and meeting care coordinating services, Healthy Gen and Pathways Community Hub Institute, and really try and look at in a very rural area where you may not have a ton of options, what could be flexible and what couldn't, or how could we maybe potentially address some of these challenges. From my perspective, you could certainly have a group that began developing an RFP that could include people who were a part of it. Crystal, when you and I initially talked about it, we had also thought about that group as being reviewers as well, which was part of why we said, you
That's
can't.
right.
Right. So that was our initial thought was, okay, we develop and do the review, that this would be sort of the RFP team. We could certainly modify that, but that was our initial thought process.
So this is Deb from Community Choice, and as a health home lead organization, and Dr. Redding and I have had lots of conversation about the similarities between a hub and a lead organization. I feel a little awkward to volunteer myself, but what I would like to be is a convener of the multiple leads, because we have multiple leads in our state. So in this region, we have 5 lead organizations that act as hub. And so convening and bringing answers to the work group that may be a question that we could be experts to answer, but not be part of that decision making to pull that conflict away. But we have 4 years of experience and data and numbers. And I think, Sheila, I think it was you a year and a half ago who I heard at an ACH board meeting saying none of the board members at that time, with the exception of probably Bruce because he's his organization is a CCO, really fully understand what health homes is and what the coverage is and what the impact is in this region. And so I am happy to convene the lead partners to come up with a presentation maybe for this work group to understand what's already happening here, to give everybody a deeper understanding of what the potential could be as well.
Great. Bruce, you had something here.
Well, certainly the standards are high in terms of the ability and the sophistication of organizations in this region. It seems like there is indeed a challenge. Well, you mentioned there are several hospital systems that got together and provided for a hub. It seems like that level of sophistication may be required. And we had some discussion earlier about a statewide hub organization being created that would serve the ACHs. I'm just wondering where that is at this time.
Kathy, question.
The statewide association of ACHs. I think the ACHs are still, we're still working together. It's kind of a slow process trying to figure out what we can do together and what we can't. There was a call just now at 2 that John was on.
So I would say, based on the call and the general feel, is that ACHs are looking at how they can get economies of scale, but I don't know that means it's one hub that is in charge of all of the different regions. It's just how can we get economies of scale under the software platform, not how can we form one ACH hub that takes care of North Central, Greater Columbia, Pierce, Southwest, and contracts with the CCA organizations within those regions. You'd still have an independent org in each of those regions doing that work.
So I think that there's a little bit more information that the subgroup can kind of get together and talk through, and we can come back to the next work group meeting with a little bit more information about the standards and prerequisites, maybe some ideas on how to do this RFP process, or find out who's interested in our area and who's eligible. Like Kathy said, that our technical assistance team is working on kind of, if any, what those eligibility criteria might be. So I'll just ask one more time. I got 3 names. Is there anybody else? And we're taking off the last bullet of constraints. Is there anybody else that wants to help with this?
This is Molly, and as an active community health worker right now in 4 counties, I would like to participate in a subgroup and see if I can add anything to it.
Great.
Crystal, this is Sheila. I have a general question.
Yeah.
So I have a question and a comment. I do agree with what Deb said. I think it would be value for this group and at the board to understand the work of the health homes. Yet, from staff's perspective, you've thought a lot about this hub project. Have there been organizations that you have thought about that might serve as the hub in our region?
We have struggled to identify somebody that would meet all of the standards and prerequisites.
Okay. And when I'm looking at what the standards and prerequisites are, is that, for example, this document that's out there from the Rockville Institute that shows the certification?
Yep, that's it.
Yeah, I agree with you.
I didn't try to make it that hard.
Have you had, it's for Dr. Redding, have you had experience with organizations or entities partnering together to meet the standards? Is that an option?
It would get really complicated, I think, pretty quickly. I think to have one, and a hub isn't a big entity. I mean, it needs to be kind of small and lean and flexible. It's, again, they're not doing the care coordination work, so you don't need to have a big staff of people. Most hubs can operate with 3 or 4 people max. That's why some communities have opted, if they just can't find an organization, to create one, because to have that neutral flavor where you're not seen as favoring, and that's really the problem, is that if you were the hub and you had your own care coordinators, even if you were totally above board, there's the perception by others that you're going to take the best, because if it's all about payments and contracts, and so it's better just to keep that hub neutral and not engaged in any of that work.
So I think this is really good conversation, and I'm excited for the subgroup. And we do have, out of the 4 people that volunteered, somebody from each county, so that's good. We'll have an idea of what's going on in the county, and maybe there are organizations that we haven't thought of that might work for it. So it's 3:17. If you guys change your mind and decide you want to be on the subgroup, email me and let me know. Caroline, do you want to discuss just a bit about this part?
So we anticipated that we might run out of time. So I had data prepared, but it's a lot of data to digest. So Crystal and I agreed that if it was past 3:15, it would be just insane to click through those things and forego a meaningful conversation about the data. So we're going to save that for the next presentation. But to this point of not having siloed projects, we've been having conversations internally as staff about how all of our 6 projects intersect and how they all work together, because there's a lot of interdependencies. So these gears on the screen are meant to represent this complex system in the way that the whole person care that we're really striving for as a region. It's a big wheel that has a lot of subcomponents, and then care coordination, as Dr. Redding said, it's in our preliminary project plan for this specific project, Pathways Hub. We actually framed it as the community-based care coordination being the real link between clinical and community settings. So that care coordination, which includes the care coordination that's already happening, and then the Pathways Hub that comes online later, that's really our key to trying to address some of the social determinants of health and really building the bridge between the clinical settings, whether it's primary care and behavioral health or hospitals, and social services. So when you look at that complex system, I think one of the things that we need to think about as a work group when we think about the target population is how can we intersect the target population so that we build overlap between our projects, right? So the transitional care and diversion interventions work group is talking a lot about ED utilization and avoiding ED utilization. The whole person care work group is talking a lot about integration of behavioral health and primary care, and also addressing and managing chronic conditions. And then the opioid work group is interrelated with both of those in that it cross, obviously it's a behavioral health issue, but it's also a chronic condition. So on this next slide, I wanted to show you that opportunities to synchronize our target population. And at the next meeting, we'll dig in to data that's in each of these categories. But if you look at the circles, right, the farther you come in to those petals, and then ultimately the center part, the little pentagon, that's where you get to the really complex social and health needs. So I think one of the tasks for this work group is, where in this diagram do you want to be? How far in and between which circles? And I actually would love to have those of you in the room who do care coordination today, let us know, like, where do you think these intersections are, and where do you think the real complex population would be that we would want to serve through the hub? Like, I'd like to go around and hear that, because it'd be interesting to hear that without looking at the data. And then next meeting, we can look at the data and see where that actually supports what you're seeing, or where that actually might kind of move us in a different direction based on what the data shows. So any of you folks on the phone from care coordination agencies have thoughts about where you would see the hub really having an opportunity to meet some complex social and health needs?
Can I speak first?
Yeah.
It cannot be anyone with a PRISM score of 1.5 and higher.
There you go.
And the Healthcare Authority has already made that clear. If they have a PRISM score of 1.5 and higher, they're eligible for health home, but health home eligibility doesn't mean they're automatically in it. It means they're eligible, and the lead organizations assigned to CCOs, who then go out and find the client and find out if the client wants to engage.
Yeah.
So it's still the client has the ultimate determination. If they choose to opt out, then they can go back into a different pool. But initially 1.5 and higher, we have to, because we would be in trouble as a state for double dipping for the care of this, because this is health home is paid from a different pot of funds. Yeah. So it has to be under 1.5. I've heard other lead orgs in other meetings talk about, would a perfect number be a target population of a 1.0 in hopes of maybe someday, you know, it's kind of like, would we put health homes out of business if we go upstream a little bit to a 1.0 up at risk for health home, but they're not quite health home? Would we alleviate the burden that's on the health home care coordination organizations right now? And the health home care coordination organizations use skilled professionals as opposed to the community health worker model. You know, so that would allow us to really tailor and focus on those super high health needs if we're nipping in the bud those at risk for, but we're helping them early. It's a real upstream approach.
That's a good point, and that's very concrete criteria. I mean, we have some data on the PRISM scores actually that our ACH got, and I did not have that in my presentation that I prepared for today, but maybe I'll bring that back and add those slides in there.
That would be good.
Because we actually got data where they show us the PRISM score breakdown by demographics and by county.
Okay.
Which is not something that, we just got that last Friday, a week ago. So I'll commit to putting that in there, because I think that's a good point.
That would be good. And I think the lead organizations getting together and also presenting to the group, the engaged, you know, if we look at the PRISM scores, the actual total PRISM scores, and then compare to the engagement, how many are actually opted in, and how, you know, I think that would be a really good cross-reference and really help us dig in a little bit deeper.
Would you be able to bring some of your health homes data?
Yeah, I have. Staff pulled some today, but I didn't quite have it mapped the way I want, but I will have it by the next meeting.
Coordinate, yeah.
And then Deb, would you be able to know, do you have it in your head already, perhaps what percentage do get into the health home program or?
That opt-in?
Yeah.
It varies across CCO, it varies across lead at the state level. Are we ready for this? At the state level, we're still only like at 11%. It's super, super low. There's lots of theory as to why, but part of it is this is a super transient population. They're really a lot of them are homeless. You know, if we think of the King County area, a lot of them are homeless. We're only given the last current information that the healthcare authority has on the client, and that's what we have to go on. So the low-hanging fruit, the ones that we had the accurate phone number for, the accurate address, and we could knock on the door, they were there. They said yes. We've engaged those folks. Now the ones that are out there and still not engaged are the ones that either we don't have current information. I've shared a couple times the one client that we couldn't find. She was on our cannot find list, didn't have a phone number. She's illiterate. So even though we sent her the letter that said you are eligible for this, like we're supposed to, the due diligence, she couldn't read it and she didn't know. And it was only because a community org was frantically searching for something for her and called us, and we discovered she was on our list, but we couldn't find her. There's a lot of those. So we can get you some ballpark numbers for sure, but statewide it's still really low. I keep saying if we engaged more, think of the savings, because just with 11%, we've saved $67 million in Medicare spending. So there's a lot of potential.
But in our area, you can have 11%. So I have to give you kudos for that.
Yeah, we have. 2023 is what we are as a lead, but we have to remember, and that's across, we contract with 3 CCOs here in this area, and we're still right about 23%. And there's other leads, you know, that would also have answers. So I can't speak for the whole. I can collect the information from the whole and get it to everybody.
I have a clarifying question on that particular point. So if we pick a target population, are we saying, Deb, that is a eliminator, possibly? So before that person is accepted into the hub for care coordination, we have to ensure that they are not engaged with a health home if they are PRISM with a 1.5 score or higher. Is it basically a rule out?
So healthcare authority said that a person who's eligible for health homes cannot be put in the hub unless the person opts out. And I can tell you that the lead orgs up in the North Sound ACH region have come together, and they're working on a process of how to triage, I guess, if you will, who could be eligible or not, just to ensure that we're not putting health home eligible folks into the pathway and delivering services and paying for services on that. So there's some work around that, and that group, I'm sure, all of the MCOs, but Melina's kind of taken the lead on that to really figure out what is the best process for triaging to ensure that we're not putting the wrong people into the hub.
Kathy's been involved with that too.
So that's right.
The next meeting, she would be able to give a presentation on that so that people understand.
I'd be happy to do that. And yes, I've been a part of that group from the beginning. And Crystal, I think I sent you that entire slide presentation on what we came up with in the North Sound area around what the relationship between health homes and pathways could be. And so, yeah, if you want to take a look at that, and I can answer questions or present it at the next group, but yeah, we've spent, I don't know, 7 or 8 months trying to figure out what that relationship would be.
Okay. I think that would be a good next step.
So this is Linda. So Kathy, the next time we get together, I just want to, I don't want to surprise you, so you can bring this back next time. Thank you. So there has been some discussion with the ACH executive directors about concerns for hubs developed in rural areas, but as a general across the whole state, the fact that our Medicaid rates are so much lower than they are in the state of Ohio and some of the other states. And whether, when we talk about sustainability, that puts you at a big disadvantage just to start out with in being successful. So I would be interested in you coming back for the next meeting and being able to, after you've had a chance to talk with your state colleagues, talk about that. And I do understand Medicaid rates are often set by the pesky legislators, but it is something that we have to bring up because it's been talked about in our ACH huddles. We really want to be successful, but that could be a barrier.
Yes, so let me make sure I understand. So you're talking about the reimbursement rates, correct? Okay, correct. Yep, I understand.
Well, it is 3:30 on the dot. I hope you guys felt like this was a good overview and are ready to dig into this. I'll be getting in touch with the 4 people that volunteered for the lead agency RFP. And then I'll also be sending out a doodle poll to the whole group to schedule the next meeting, along with some links to the Pathways Hub manual and a quick start guide that go a little bit more in depth than what the presentation did today, which would be helpful to read. And I'll also send the standards and prerequisites. They are linked on the presentation that was added to your calendar invite today, but I'll also send them an email just so you have them. And one last thing before we stop is there's a membership agreement for being part of this work group. If you're here in the room, you have it printed out in front of you. If you're on the phone, it was added to the calendar invite. Please sign that if you want to stay part of this work group and email it back to me or give it to me at the next meeting. Thank you. Thank you.
Bye, everyone.
Bye. Have a great weekend.
Okay. Does it only get to be one of us? Oh, okay. All right.
Yeah.